everyone, and welcome to WCAP's Race Across the Pond initiative panel discussion titled Global Perspective on Institutional Racism and Inequality in the Healthcare System. This event is part of our series on women of color in the healthcare system. We're really excited to welcome you for this great discussion that opens the new season of the WCAP's Race Across the Pond initiative. Thank you for joining us from many parts of the world. And before I start, please note that the conversation will be in English. If you wish, you can access our online translation platform. The information will be shared in the comment box. Bonsoir à toutes et à tous et bienvenue à notre événement intitulé Racisme institutionnel et inégalité en santé dans le monde. Cet événement est organisé par l'initiative Race Across the Pond de WCAPS et la discussion sera conduite en anglais. Vous avez la possibilité d'accéder à notre plateforme de traduction digitale si vous le souhaitez. Les détails sont partagés dans la boîte à commentaires. My name is Sherry-Ann. I'm a public health professional and member of Race Across the Pond initiative, also called RAP initiative. I am also a researcher for our Women of Color in Healthcare System series. Today, I will moderate this event with my colleague Yasmin El-Adouli.
Hello, everybody. My name is Yasmin, and I am a public health professional like Sherry-Ann. I am also a member of the Race Across the Pond initiative and a researcher for our Women of Color in the Healthcare System series. And I am excited to co-moderate this event with you today.
Before starting, some quick housekeeping. Please feel free to talk in the chat. We'd love to see you engaging in a discussion, share your thoughts, and also, please always be respectful to each other. I am convinced, I do not have to say it, but for well-being of everyone, especially our speakers, I would like to tell you that any disrespectful comment or hateful speech aimed at our speaker or anyone in the audience will result in the immediate exclusion of their authors. If you have any questions specific to any panelist, please mention whom is it directed towards, and we will share it later on. We'll also use the chat box on our site to share with you important links. Please keep your microphone off, but feel free to put your camera on. You can visit our WCAP's website and check the Race Across the Pond initiative page. Links are shared in the comment box right now. Throughout this event, feel free to tweet or post on Instagram, LinkedIn, Twitter, or Facebook using hashtag WCAPS initiative and tagging WCAPSnet. This event is recorded and will be available soon on our WCAPS RAP initiative YouTube channel and website page. The conversation will last approximately 1.5 hours and will be divided in 3 parts. During the first half an hour, the panelists will introduce their work and research on how racism and intersectional discrimination are affecting the health of communities of color, in particular women and girls of color, in their country or region of interest. We will continue with a round of questions led by my colleague Yasmin and myself, and then we'll finish with some time at the end of the conversation with a Q&A session for questions from the audience. So please share your question in the chat box. Before we start, I would like to thank our colleagues from the RAP initiative who have worked with us to prepare this event, Hadil Ali, Sarah Buhush, and Laetitia Diatezua. We also want to thank WCAPS Canada, UK, France, and WCAPS SWANA Working Group who have co-sponsored this event. Thank you for your support. I will now hand over to Sarah Buhush, the founder and chair of WCAP's Race Across the Pond initiative, and give a few words about the organization and the project.
Hi, everyone. Good afternoon, good evening, depending on where you are. Thank you so much, Sherry-Ann. Thank you, Yasmin, for everything you have been doing to prepare this event. So my name is Sarah Buhush. I'm the chair and founder of the RAP initiative, which stands for the Race Across the Pond initiative. It is a project of WCAPS. And WCAPS is an organization that stands himself for Women of Color Advancing Peace, Security, and Conflict Transformation. It's an organization that has been created 4 years ago by Undersecretary of State Bonnie Jenkins. And it aims to advance the leadership of women of color in the field of peace and security internationally. We have chapters in different countries, including in UK, in France, in Canada, in Nigeria, in Ghana, and many other countries. We also have dozens of working groups looking into different areas of security and peace and different initiatives. About the RAP initiative, a few words to explain a little bit what we do. So it's a project, as I said, it's an international project of the WCAPS. I created this initiative at the end of last year with the intention to fill a gap. My intention was with this initiative to bring the topic of constructed race and racism at the center of the debate, the international debate and the dialogues around peace and security, because most of the time, unfortunately, it is either on the very side of the topics, of the main topics, or not discussed at all. And so we aim in the initiative to explore from an intersectional lens how constructed race and racism impact the lives and human security of communities of color globally and how they threaten international peace and security. We analyze and intend to deconstruct the different mechanisms leveraged by racial and racist systems from a wide range of perspectives and methodologies. And we raise the voices of women of color who are leading change in their own countries and beyond. And most importantly, we provide a safe space where we invite women of color and allies to discuss and to challenge the collective and individual mentalities across cultures, to fight against white supremacy, neocolonialism, racism, and intersectional discriminations. We are organized different series, which are topic-based projects. One of them is Women of Color in Healthcare Systems. And this is through this series that this event is organized. And as part of it, I would like to thank again Yasmin and Sherihan and inform you that they have been writing a policy paper that will be published in the coming days, so please stay tuned. It is looking at the institutional and systemic racism and discrimination in healthcare in France. We will have other publication in the future. But for this paper that is coming up, please stay tuned on and follow us on social media and on our website. And on that, thank you, everyone. And I hand over to you back, Sherihan.
Thank you, Sarah. A little bit more about this paper before starting. Indeed, for this policy paper, we will provide an overview on the French legal framework. We develop on different forms of discrimination faced by racialized and minority group, and we expand on the social determinant of health. We will also cover in this paper issues related to the risks posed by the lack of diversity in clinical trial, the Mediterranean syndrome, or the exacerbation of the inequalities during the pandemic crisis. In this paper, we focus both on access to healthcare and quality of care, topics that actually will be also discussed today during the presentations. While providing this kind of information about the healthcare system in France, we will also provide sets of recommendations on how France can ensure more equity in the healthcare system for racialized and minority groups. The paper will be out this week, and we will share more information on our social media and webpage. And now I will let Yasmin introduce our speakers.
So the first speaker is Lazenya Richemond, she is a global health specialist with over 12 years experience in global health. Her specialty areas are in program management, grant management, and strategic planning across a variety of public health areas, including neglected tropical disease, non-communicable disease, maternal, adolescent, and child health. She has lived and worked in sub-Saharan Africa, the Caribbean, Middle East, South, and Southeast Asia. She also has a keen interest in exploring intersectionality in global health to reduce health inequalities. Lazenya recently transitioned to working with the UK National Health Service as a senior strategy manager in the National Cancer Programme. Her prior expertise driving projects forward under challenging circumstances has set her in good stead to undertake the task at hand and improve cancer diagnosis, treatment and survival rates across England during the COVID-19 pandemic and beyond. Welcome, Lazenya. Rasha Saba, head of MENA department for the organization Minority Rights Groups. Rasha is a human rights professional with over 9 years of experience working in fields of public health and human rights with a focus on women, minorities, and refugees in the Middle East and North African region. Rasha holds a master's degree in global health from King's College London. She authored a number of reports and is currently working at Minority Rights Group International as the head of Middle East and North Africa programs. Welcome, Rasha. Estelle Carde is a professor of sociology at the University of Montreal and a researcher at CREMIS, Montreal Research Center on Social Inequalities, Discrimination, and Alternative Citizenship Practices in Canada. Trained in social science as well as medicine, she works on social inequalities in health and particularly on racial discrimination in health. Her research fields are France, including French Guiana and Quebec. Currently, Estelle Carde is interested in social inequalities in the face of the COVID pandemic. In addition, she is conducting a study on social inequalities in the credibility of people suffering from chronic pain in Montreal. Finally, she is developing a more theoretical reflection on the notions of social inequalities and on that of intersectionality. Welcome, Estelle. Aimee Bouke is a rural family physician based in Inuvik, Northwest Territories, practicing in Gwinch, I'm not sure how to say it, and Inuvianuit territories. She holds an MD from the University of Sherbrooke and a Master in Human Genetics from McGill University and a Bachelor from University of Ottawa. Prior to medicine, she spent over a decade as a member of the Canadian Forces Reserves. Dr. Bouke served as the section of residence vice chair for the College of Family Physicians of Canada and is the outgoing co-chair of the Alberta chapter of the Canadian Association of Physicians for the Environment. She currently sits on the board of advisor of Black Physicians of Alberta Association. Being a Black Francophone woman raising Afro-Indigenous children has shaped most of her experiences in medicine, both as a patient and a practitioner. Her main interests are intersectional environmentalism, as well as anti-racism frameworks and anti-oppression in medicine. She remains hopeful that equity-based medicine will lead to better health outcomes for marginalized population. Welcome, Aimee. Now I'm going to give the floor to our panelists for their presentation, and we can start with Aimee Bouke if she's ready.
Yes, absolutely. First of all, thank you so much for creating a platform where we could share our work and our interests. I'm extremely grateful for this opportunity to participate in this session on institutional racism and inequalities in healthcare. Before I start talking, I'd like to acknowledge that I'm presenting from the Gwich'in and Inuvialuit territories in the Western Arctic. I'm a guest on this land. This place has been inhabited by Indigenous peoples for millennia, and this region is a place where the caribou is king. Some of my content might be triggering to some, so I would like to highlight that I'll be discussing some trauma that pertains to Indigenous people in Canada, as well as Black communities in Canada. So feel free to mute or disconnect if this becomes too overwhelming for you. This presentation will aim to discuss a few things: the racism in healthcare within the Canadian context, in the context of historical policies that are lasting and have ongoing consequences. I will also be discussing the interpersonal, institutional, and systemic racism and how they all contribute to poor health outcomes in racialized communities in Canada. And then I will also talk about how if racism is a social determinant of health, anti-racism is a public health intervention, to end as well with dismantling white supremacy in healthcare will require restructuring human resources efforts, medical education, and care delivery. So I'm speaking with the lens of a practitioner who dabbles in public health. Most of my co-panelists are experts. I dabble because of my experiences in the field and the need of restructuring the medical environment and medical education specifically regarding systemic racism. So for decades, the colonial state of Canada sat on a very comfortable reputation of benevolent peacemakers, peace seekers. This nation actually was built on genocide, slavery, exploitation, and land theft. And the state actually put a lot of effort to sanitize and whitewash history. It has become harder over time to camouflage the very calculated and very strategic efforts that the state deployed to decimate populations and assume control of resources over the land. In fact, a lot of people don't know that the apartheid was in fact inspired by the Indian Act that was created in 1867 to control Indigenous people on the land of Canada. Sorry about this. I wanted to provide very clear examples that related to health in the context of discriminatory policies and frameworks in this country. I'd like to approach one key example called the Indian hospitals. Indian hospitals operated between the 19th and 20th centuries, and the concept sounded benevolent, was to provide a space for Indigenous patients to receive care. However, it was very, very clear that these institutions were based and created to perpetrate cultural genocide and assimilation by banning traditional healing methods and also isolating Indigenous patients because of illnesses like TB. So ultimately, settlers believed that Indian TB was more dangerous to the non-Indigenous population, and then it required this framework or institution to be created to protect the rest of the white population. It led by separating individuals from communities, social networks, and blatant segregation, inequalities in care, and of course, some level of experimentation. Ultimately, it was a tool of imprisonment and death. A lot of individuals who were forced to be sent to Indian hospitals had no choice. So if you tried to escape from one of the hospitals, the police would be sent after you to be sent again to these hospitals. Ultimately, you would be receiving less care and often spent months, if not years, being treated for TB and then pass away in these institutions and eventually be lost to your community. Another very clear example has been the coercive sterilization of Indigenous women, which was operating from the early to mid 20th century and is still ongoing. And I will add a bit of details around this in a moment. So forced sterilization was based on a eugenic idea and a policy which not only specifically targeted Indigenous women, but overall made in sort that Indigenous women were overly represented. Ultimately, the government started obtaining consent to avoid litigation and to avoid human rights claims. But today we are aware of current class action suits that are being put forward with women who have not been provided appropriate consent, who have been pressured to undergo sterilization within this healthcare system with practitioners who are currently practicing today. And the last example I wanted to provide was nutritional studies in the residential school system. The residential school system was a system put in place by the government to strip children from Indigenous parents and sensibly commit cultural genocide. They were aiming to basically kill the Indian in the child. In that process, they ended up murdering a good quantity of children that we are currently unearthing right now in Canada. And during those during that period that lasted until 1996, some studies were designed to study the longitudinal impacts of malnutrition without parental consent. by unethically dividing control and treatment groups, sometimes providing some good nutrition or poor nutrition to some and to others, leading to very poor health outcomes. If we acknowledge the consequences of these discriminatory practices and ongoing white supremacist frameworks, we will identify specific statistics that highlight the disparities of health between Indigenous communities in Canada and settlers on the land. At this point, Inuit individuals are 200 times more likely to contract TB than non-Indigenous Canadians. And some of the reasoning behind those huge disparities are basically detailed on the fact that a lot of Indigenous and Inuit individuals struggle with food insecurity. They struggle with overcrowded, poorly ventilated homes, and are in close contact with other individuals who have untreated active TB. Very quickly, I'd like to present a few cases of interpersonal, institutional, and systemic racism in the context of Canadian healthcare. Recently, about a year ago, a 37-year-old woman called Joyce Ishakwan, an Indigenous woman, mother of 7 children, attended a Quebec emergency room in September of 2020. She endured racist abuse and actually recorded her last moment, leading to her death. Ultimately, a report was published confirming her cause of death being heart failure while she was being treated for opioid addiction, despite the fact that she actually had an opioid allergy or intolerance. So these were specific individuals who berated a patient within a racist institution supported by institutional and systemic racism on a regional basis. So how this case is basically the poster child of how interpersonal, institutional, and systemic racism play together to lead to very poor outcome in health for Indigenous individuals. Ultimately, a few key elements that are needed to change or to improve the healthcare system in Canada in the context of race basically rely on accountability, on equity-based healthcare delivery guidelines and processes, and third-party review of health policies. I am currently working actively to provide medical education frameworks on anti-racism and anti-oppressive frameworks in medical education. And ultimately, the context of EDI, or equity, diversity, and inclusion, needs to go through leadership opportunities to people who are racialized or marginalized in any other ways. Providing diversity without providing tools and providing leadership is very, very performative. And then we also have to remember that the master's tools cannot dismantle the master's house. The Truth and Reconciliation Committee report published in 2015 by stakeholders, Indigenous stakeholders, provide examples or key processes to improve the health of Indigenous Canadians. The processes have already been written. All that is left is to actually enact them and provide support for these policies to exist. So I'll be looking forward to some of your questions later on.
Thank you very much. That was very, very interesting. Estelle Carde, would you like to go next?
Sure. Hello, thank you for this invitation, and thank you, Aimee, for this very powerful, strong presentation, which started the whole thing. When I first think of racism in health, I usually think of racist discriminations in access to healthcare. And then I think of refusals of healthcare, which is shocking, but also of what is less obvious, but very frequent, such as making someone wait longer, treating them with less empathy, and so on. But a question that I asked myself a few years ago when I was doing my thesis in sociology was, how do the perpetrators of discrimination, of everyday, healthcare discrimination, how do they justify these discriminations? How do the authors of this discrimination justify themselves? And so that's a question I asked in my sociology thesis. So I was in France, and in France, I went to meet some healthcare professionals, and I asked them questions trying to identify their justifications. And so I would like to present two of these kind of very everyday life justifications. One was extremely common. It happened with foreigners, and it happened especially not with providing care, but more with granting the right to health coverage, especially to undocumented foreigners. And so these professionals would tell me that they were requiring documents that actually were not required by the law. Like they would say to the people, well, if you want to have a health coverage, you need such or such document. And these documents were not required by the law. But the professionals would tell me, well, this is legitimate to ask things which are not asked by the law, because these people, foreigners, do not deserve to be in France since they are undocumented foreigners, and therefore they do not deserve to be helped by the French social system through the health coverage. And so they were saying that quite frankly. And actually, the reason why they were so frank is that they were relying on some politics, government politics, which have been going on for at least 30 years, but you can say even more, 50 years. And these politics tend to be in France, like in other countries too, but particularly in France, they tend to be more and more restrictive of immigration and of social rights for undocumented foreigners. And so the message that is transmitted to the general population through these policies is that it would be in the common interest of the country to make it more difficult for foreigners to access social rights, including right to healthcare, because foreigners are too many. There are too many in France. They take too much employment to French people, and then when they want to get access to healthcare, they cost too much to the country, and so on. And so the professionals that would pretend that by limiting access to healthcare, health coverage, they pretended that they were just helping to enforce the law, even though they were actually going beyond the law. They were illegal. They were actually discriminating. The second type of discrimination that I would like to discuss here is much more insidious, because it does not consist in saying that some people are less deserving of access to care. It is about saying that these people, some people are so culturally different that the care offered to them should be adapted. And it is a discrimination when, first, this perceived difference is an abusive generalization. So that's what we call culturalism, in English. And this is also discrimination because this adaptation is actually offering a worse treatment that the treatment that you would offer to anybody. So I give you just a very short example that seems not so bad, but it actually is a discrimination. I have heard it often when I was working in French Guiana. French professionals, French healthcare professionals, they would not ask pregnant women for their informed consent before testing them for HIV, because you do an HIV test for each pregnant woman who is followed at the hospital. And so they would not warn them, they would not let them know that they were doing this test, because these women were from a particular ethnicity, Noir Marron in French Guiana. And the stereotype was that they would not understand, because of their culture, what was HIV. So it was too complicated to try to go into this kind of talk to explain them and so on, because anyway, most of them were negative anyway. So it was not worth let's just do the test and not tell them. So that's two kinds of discrimination that I wanted to talk about, discrimination in healthcare. But actually, when you analyze racism in health, of course, it is important to go beyond the question of discrimination in access to healthcare. Because if racism affects health, it is because it affects many determinants of health, and care is only one of them. Like if you talk about quality of the housing, working conditions, education level, all these are determinants of health. And actually, all of those can be restricted because of racism. Probably the most important of all this is income. Income is a major determinant of health, and many discriminations in access to various resources, such as housing, work, education, and so on, all these discrimination end up depriving racial minorities from money because you pay more for your housing, you don't get the work that you wanted to get, and so on. So since racial minorities are in a worse health than the racial majority because they have less money, then it is very important to not stop the analysis there and to analyze how each discrimination that tends to make racial minorities poorer tend also to affect their health. So that's a second step in the analysis that I think is too often forgotten. And finally, it's important to not forget the less visible pathways through which racism affects people's health. Because to be a victim of racist discrimination, it's not only to be deprived from a resource, like a job, a house, and so on, but it's also to feel victim of an injustice. It's to feel vulnerable. It's to feel that you are confronted to hostility. And this is a stress. It's an acute stress for each new discrimination, but it's also a chronic stress because of this persistent feeling of vulnerability all life long. And this stress raises the risk for psychological distress, for unhealthy behavioral coping responses, like tobacco use, alcohol abuse, and so on. Stress also modifies people biologically, even though they might not be aware of it, like the neuroendocrine system, the autonomic system, the immune system are all affected by stress. And all this is a risk factor for many various diseases. And finally, a last word about the intersectional perspective. Each person is situated somewhere in the racial power relationship, but each of us is also situated somewhere on other power relationships, like gender relationship, socioeconomic relationship, and so on. And the impact of racism on the health of a given person depends not only on her race, but also on her gender, her socioeconomic status, her sexual orientation, and so on. And so it's always very important to consider that the health of a racialized person won't be hurt whether this person won't be hurt in the same way, whether this person is a woman or a man, is rich or poor, and so on. Every time it will be hurt by racism, but differently according to the combination of positions that this person holds simultaneously. That's it. I don't know how long I talked, but
Thank you very much, Estelle. It was very interesting. We actually used your work in the article, so we hope you're going to enjoy it. Now, Lazenya, would you like to go next?
Thanks, Yasmin. Hi, everyone. I'm Lazenya Richemond, and I'm going to be talking about maternal health statistics in the UK. So as a Black woman who's living in the UK, I would be 5 times more likely to die during pregnancy and in the 6 weeks after childbirth. I also have an 80% chance of having a maternal morbidity. So that's having a complication after pregnancy and having some severe complication as a result of my childbirth. And these statistics are in comparison to white women. If I was an Asian woman, I would have been twice as likely to die during childbirth and pregnancy. And these really are the shocking maternal health disparities that we're seeing in 21st century Britain. One of the reasons for the disparities is the racial bias against women of color in terms of the service that they're receiving from healthcare providers. Black and minority ethnic women, we don't feel like we're treated equally within the UK health system. And a recent poll showed that 78% of Black women actually felt that they'll be unfairly treated in the UK health system. Black and minority ethnic women, we don't feel that we're listened to, and we don't feel satisfied with the level of service that we receive from healthcare practitioners. But the bias isn't actually only at healthcare practitioner level, it's a systemic issue within the health system. About 2 months ago, there were national guidelines that were released that recommended that Black and minority ethnic women are induced for their labor at 39 weeks, as opposed to white women who were recommended to be induced at 41 weeks. And there was no clinical evidence that this would improve the outcome for Black and minority ethnic women if they were induced at 39 weeks as opposed to 41 weeks for white women. And this actually caused quite a lot of outrage in the UK. And there have been Twitter campaigns called Not So Nice. I'm not sure if anyone has heard of it, but really putting pressure on the National Institute of Clinical Excellence to review this draft guidelines, because it is a discriminatory policy against Black and minority ethnic women. The racial bias that we see in the UK, it's not only towards patients of the healthcare system, practitioners also have faced racial bias. So Black and minority ethnic doctors in the UK make up about 29% of doctors, but 42% of complaints are actually against Black and minority ethnic doctors, and they're 50% more likely to receive a warning than their white counterparts. And a few months ago, a tribunal actually ruled that the General Medical Council racially discriminated against a Black doctor. He was investigated for something, while a white doctor who had the same discretion, his case was dismissed. And I mention Black and minority ethnic doctors because research has shown that if you have a doctor that's the same ethnicity as you, your health outcomes are actually better, and you have a greater satisfaction with the service that's provided. So if we have Black and minority ethnic doctors who are being racially biased, it means that they're more likely to leave the system, and that's going to have a knock-on impact on the health outcomes of minoritized populations in the UK. I just want to close by saying, health is a human right. It is a fundamental human right. And we're seeing within the UK that certain populations, specifically marginalized populations, and racially marginalized populations, they're suffering higher rates of ill health. And this is really due to racism. There are other factors. And the two other panelists, Dr. Aimee and Estelle, touched on them, the social determinants of health. They do contribute to ill health. But racism and racial bias is directly impacting on the health of racial populations in the UK, and it is a public health issue that needs to be urgently addressed. In terms of what I have been doing to address the maternal health disparity in the UK, I've recently written an article about the maternal health disparities in the UK, and I believe the hosts are going to be sharing it in the chat box. And there's also different campaigns that are running that I have been part of. So there's a 5 times more campaign that was set up by 2 Black women who have gone through the whole process of pregnancy and childbirth and being outraged with the 5 times more statistic. And they've actually lobbied the government. In April, there was a meeting in Parliament where the government had to respond to this petition. So we're just waiting to hear back from the government, the UK government, on what will be done. But one of the things that I believe should be done is to have a date for when this disparity would be removed. There's no reason for us in 2021 to have one group dying 5 times more than another group. So I look forward to continuing this conversation. I'm sure that there will be some questions for me, so I will hand over to the moderator. Thank you.
Thank you very much, Lazenya. It was very interesting. Now we have Rasha.
Yeah. Thank you so much. Hi. Hi, Yasmin. Thank you, Yasmin. And thanks, everyone, the speakers, for these very informative, very interesting interventions. Very glad to join you today. I will take you to a bit like further, another region, which is the Middle East and North Africa. So basically, I will focus on 2 points in my presentation today to try to highlight some of the issues on how institutional racism has shaped the experiences of racial and ethnic minorities in the region, in the Middle East and North Africa, by giving a couple of examples from 2 countries. So I will look at, the first point will be on evidence we found of structures that can affect health status of minorities in the region. And these can include, but not limited to, access to documentation, investing in social infrastructures, language barriers, segregation, and access to labor rights. And I think Estelle touched upon these, like on how other determinants actually affect the health, and we can see like many issues in the region related to that. Yeah, it's just to say before I get into my presentation, it is a very complicated and very complex issue. It hasn't been documented, sadly, but there is a momentum now to talk about racism and to highlight some of the issues that face minorities in the region. So I will highlight this situation here in Tunisia. We can see how policies like investment in social infrastructure determine health status for many minorities. For example, Black Tunisian are one of the minority groups in the country that suffer from long history of discrimination and social exclusion. They struggle to access to quality healthcare due to poor health infrastructures available in areas dominated by these groups. And here I would like to highlight a couple of things. There is no official information or statistic available on the health situation of Black Tunisians and other minorities in Tunisia. And I guess this is the case also across the region. Studies available has mostly looked at the health disparities between regions and highlighted worse health outcomes in the south of the country, where actually many minorities reside. Other factors such as access to documentation, language, and segregation can be seen clearly within, in the case of migrants. This is true in a few countries, and if we stay in Tunisia, the example of Tunisia, for those who are not familiar, Tunisia is a transit country especially for migrants coming from the sub-Saharan region, and can end up staying there for longer than anticipated. There is no statistic on how many migrants are documented, undocumented migrants there. And so some migrants have been denied treatment based on lack of documentation that is been documented through, we have seen that through the documentation of our network of local organizations that working with these groups. Also, language barriers and the interaction with the medical staff in hospitals is reported to as one of the issues that determine access to treatment. My second point also highlight how the experience of women within these minorities are also different, the gender nature of racism, where women from racialized groups face discrimination on different bases, on the basis of their ethnicity, nationality, disability, of course, socioeconomic status, and of course their gender. Here I would give the example of migrant domestic workers in Lebanon, who are dominantly like women, over 90% of migrant domestic workers are women. Also majority coming from African countries. Access to healthcare by these migrants, by these workers, is very restricted in Lebanon. And Lebanon has this also, it's a bit different because also the health system there is highly privatized. So the access for migrants actually determined due to the nature of their employment model to which they are tied to, known as kafala system. It's also similar to what usually migrants workers also usually are tied to the contracts and the Gulf state. But for migrant workers in Lebanon, their access can be determined often by long working hours, low wages, restriction of their movements, on their communication with outside world, poor living conditions, and lack of privacy. Many are also survivors of physical and sexual abuse. So you can see this is like condition of modern slavery actually. So also here, there's no statistic on health disparities. However, there is clear evidence of high prevalence of mental health issues among migrant domestic workers. And of course, it reflects the hardship they have endured while living and working in Lebanon. This has been sadly reflected in the high rate of suicide and suicidal attempts among migrant workers, which has been documented by also many local organizations working on migrant rights and worker rights. So I will end my presentation with this sad fact, but I hope you will have the chance to ask wherever you feel like it. Thank you.
Thank you very much. Thank you very much to all of you for your precious knowledge. And now we are going to ask you a few questions, me and Sherian, before the Q&A session. And to the people, don't hesitate to share your question in the comment box. Rasha, since you were talking about Tunisia and Lebanon, I would like to start with you, if it's okay, for the first question. In your point of view, how the COVID-19 has worsened the access and the quality of care for racialized and minority groups, and particularly for women and girls in the regions of interest, such as Lebanon or Tunisia?
Okay, thank you. I guess in terms of there are like so many aspects to the impact of COVID-19 on minorities in general, but also in terms of their access to care during the pandemic, and especially in the context where, in the region where there is we're competing on resources, and especially like in the first stage of the pandemic, there were like resources such as like PPE, treatment, testing are very scarce and limited. So the competition would be on access to free tests. So we documented a few like cases where like especially migrants. And if I want to stay on the case of Lebanon, for example, in the case of refugees, in the case of migrants also, you know, like testing, access to treatment was denied or determined by being citizen or belonging to the national of the state rather than being open to everyone. So yeah, many have been denied on the basis of their nationality or on the basis of their access to documentation. And the case of domestic workers, actually, many of them, they don't have access to their passports because the sponsors will withhold their IDs and their passports. So it is a very complicated situation for them. They also been locked into houses for long and couldn't actually get access to the health system. So that in that case, like the access to treatment, yes, there were like many challenges, and yeah. So and of course in the situation of many migrants, and like also in Tunisia, the living condition where, you know, like many people sharing same households, and that definitely affect their you know, like how easy they get infected and the transmission of COVID-19. And of course, the underlying issue, like the underlying health conditions that we don't know anything about that. We don't have documentation on health situation of these minorities in the first place to actually see if how this played out during the pandemic. Thank you.
Thank you very much. Does anyone else want to give an answer? Maybe Lazenya.
I'm not Lazenya, but
Or, yes, or
Go ahead, Aimee.
Go ahead.
no worries. So I'm not Lazenya, but I do have a bit of insight that I want to provide you around the COVID pandemic, specifically as a healthcare provider who's been working in the trenches during that time as well. I'm just going to share a very quick link about an article my sister, who's a political scientist at Queen's University, and I wrote together earlier in the pandemic. That highlights some of the blind spots around how our institutions were very neglectful, once again, neglectful around racialized minorities specifically, and the outbreaks around COVID-19. Something very particular about Canada is that our governments do not gather race-based data in health. The reason why we have more information around Indigenous status revolves around historical discriminatory practices and known health gaps. There is this illusion that racialized Canadians and racialized individuals living in Canada don't necessarily experience the same level of discrimination or impacts on health that our neighbors in the South. But it was very quickly during the pandemic that we've noticed that neighborhoods that were more diverse and that had more racialized individuals tended to have higher cases of COVID, and we're probably noticing death rates that were 2 to 3 times higher than non-diverse neighborhoods. So we don't have individual data, but we can extrapolate from this information. And that comes down to where these individuals work and what are their working conditions and their labor conditions and the restrictions in terms of health access. Most more affluent white Canadians can self-isolate and work from home. It is not the case for people who have been working in the trenches in essential, quote unquote, services, where unfortunately access to PPE, but even the capacity to socially or physically distance were very, very limited. And ultimately, the delay around providing better public health policies in those workplaces were delayed for economical reasons. prime example was the Cargill outbreak in Alberta, in Canada, in southern Alberta, where workers and their families and the direct extension of these individuals accounted for almost half of the cases in that province at one time of the pandemic, because of privatization of some of these areas that led to some companies asking workers to return to work despite the fact that they needed to self-isolate. And that was uncovered a bit later on in the pandemic by actually interviewing some of the workers. But initially, most of the governmental actors were actually blaming the workers for contracting COVID, explaining that they had not followed procedures around self-isolating, around not sharing physical spaces, when all of these elements were due to the living conditions and the financial restrictions that these workers had.
Thank you very much. That's crazy. Thank you very much. Estelle or Lazenya, would you like to talk about this question a little, or?
Sure. I don't know about Lazenya. I don't see her, but sorry. Okay. I really would go along what just Aimee said. I really agree with the fact that there is a higher risk of being infected with the COVID because of the concentration of racialized persons into certain kinds of jobs, like essential services. And for many racialized women to be working in a supermarket as a cashier or as a healthcare worker, I mean, there are a higher proportion of racialized women among these working people. Also because, like Aimee said, also the kind of neighborhood with higher density, it's more difficult to escape from the COVID. And this is clearly because of COVID. You don't choose to live in this kind of neighborhood, so because of these discriminations that I was talking about. But maybe something else that I wanted to say is that it's not only more risk to be exposed and to be infected by the COVID, but it's also probably more risk to die from the infection once you are infected because of the state of health, which is already degraded from chronic illness, from stress, and all this from racism. Also, once you're infected, it would be important to compare the kind of healthcare that you actually get, like if you don't have the health coverage insurance, if you live in a neighborhood with few healthcare services, especially now in time of COVID, when the healthcare system is completely overwhelmed by the COVID, it's important to be able to negotiate when you actually want to get some healthcare. And so racial minorities might be less in a position to obtain what they need. So that's it.
Thank you. Yeah, it brings us back to the social determinants of health somehow. Lazenya, do you want to answer too?
Yes. So we're seeing exactly the same thing in the UK, as Estelle and Dr. Aimee has mentioned. In the UK, ethnic minorities are more likely to die of COVID, and they're more likely to have COVID very severe that they're requiring ICU interventions. In terms of access, I'm thinking now of Black women or minoritized women. Data from the UK has actually shown that, the health-seeking behaviors of minorities are actually lower because of the negative experience that they're having when encountering the health system. And COVID has just exacerbated that. So whereas before, I really wouldn't want to engage with the health system, and I'm saying I, as a Black woman or as a minority woman, wouldn't really want to engage with the health system. Now COVID has come and made the waiting times for certain services even longer, which means that minority ethnic groups are less likely to engage with the health system. And I think this is really going to show in a few years how different conditions, particularly non-communicable diseases, that they're going to be exacerbated as a result of COVID, just having the longer waiting times, the cultural insensitivity by healthcare practitioners. Everyone's stressed out with COVID. So if before you would have a certain level of care, by a healthcare provider. Now, because the focus is on COVID, a 20-minute appointment might just be a 10-minute appointment, and you don't even feel like your needs are met. So I think it's going to be another pandemic that we see in a few years as a result of the COVID pandemic, especially among minoritized groups. Thanks.
Thank you for this insightful reflection and really interesting point of view, and also analysis. I would like to add a question and have the perspective of the panelists on a broader question, and maybe have some of your recommendation, even if you don't have precise example. In your point of view, what can be done at civil society and or government levels to address racism and intersectional discrimination and ensure more equity in the healthcare system? And I would like maybe to hear first from Rasha and see maybe if there is something particular about the MENA region and her work at her in the civil society.
Yes, of course. Thank you. Yeah, I think this is a good question. I guess like what we struggle, and I think someone also in the chat asked the question about like, you know, like the challenges as a researcher in the region. I think one of the challenges, especially in the area of health and public health, is the lack of disaggregated data. So we definitely need more, like we need governments to work actively on collecting data that is disaggregated according to not only gender, of course, but also according to ethnicity, religion, language, and disability. We will need that to understand the you know, like health status and disparities in the region more precisely. Yeah, as I said, it is one of the biggest challenges to actually go and advocate for on health issues, for especially like for minorities in the region. I think another thing is to definitely bringing voices from local communities and be open to you know, like hear the arguments, hear their narrative. They're the one who can who understand what works and what don't work, what actually like on daily basis what they struggle with. And I think COVID actually yes, like has so many adverse and negative consequences, but actually activate some grassroots structures and community structures. So there are like some structure of resilience. I'm not romanticizing that, but this is actually how communities and like especially minorities actually face this pandemic, and this is a global crisis. So using these structure of resilience, respecting that, like trying to hear the voices and the narrative of the community, and try to bring that into the, you know, like decision-making process beyond the politics of representation. Yeah, thank you.
Thank you. And I would like to hear maybe from Aimee, from her perspective as a healthcare professional, and do you have any thoughts about it?
I try not to wallow in pessimism in general. I am actually working hard to become optimistic and to remain optimistic around the healthcare system. Because I feel like often we pretend we don't have the information and the data to do the significant work that needs to be done to increase and improve health outcomes in racialized and indigenous individuals. However, I feel like ultimately what is needed is a level of political will, and also basically restructuring some of our hierarchy in the healthcare environment and in the health policy environment to promote the presence of Black, Indigenous women and other women of color in the field to really tackle these issues. There are great initiatives that have been spearheaded in the conjuncture of the Black Lives Matter movement, as well as here in Canada, the unearthing of the bodies of children who had passed away and had been killed during the residential school system. So I think the intersection of these crucial moments are forcing the government's hands to be more proactive and a bit more generous in the amount of money they provide in budgets to tackle these issues. Because ultimately, this level of awareness is known to most government officials. A question of prioritization is the main issue when it comes to allocating budgets. And then a question of avoiding being paternalistic in their approach is also very difficult. I work in over the 66 parallel, where the differences between being a province and a territory are very starkly and very important. In territories, health policies and procedures are mandated by the federal government, and they are the day-to-day actions are delegated to territories. That means that in areas where majority Indigenous individuals live or even suffer illness, they are not overwhelmingly the ones making the decisions about where money will go in terms of healthcare. And that's a huge issue that needs to be addressed.
Thank you, really interesting. And indeed, it's a really big issue. I would like maybe to hear from Lazenya and a bit on the perspective from UK/Europe, let's say, and see what do you think, or do you have any example, a precise program or something?
Yeah, I'll speak from a UK perspective because we're no longer in the EU. So in terms of what the government can do, the government has been working. I wouldn't say that they're working very, very hard, but they have been working. So last year, they set up the Race and Health Observatory within the NHS. And this observatory is going to be tackling the ethnic inequalities in health. So I'm actually looking keenly to see what will be done in terms of the maternal health disparity that we see between Black women, white women, and Asian women. So that's one of the things that has actually come out of the pandemic. Another thing that I think the UK government could do, the UK health system could do, is to have more targeted health services for minoritized women. I think currently the services that are offered are very, centered on the average white woman. There's not the cultural sensitivities that I would like to see in initiatives. And if we have services that are not really meeting the needs of certain groups, they're not going to use those groups. So that's one thing that I would like to see specifically in maternal health, because I think that could go towards contributing to reducing the maternal mortality rates that we see. And I think in terms of advocacy, this is where civil society comes in. Dr. Aimee and Rasha had mentioned that there's no data in the regions where they work, whereas in the UK we have the data. It's been 20 years that we're talking about 5 times more, 4 times more likely to die, but it's just that nothing has been done. So I think civil society can hold the government to account. One of the things that was brought up at the parliamentary meeting in April as a result of the campaign was, when are we going to end the maternal mortality disparity? And the MP who was answering the questions couldn't really give a date. And that's something that I think civil society can continue to push for. When is the date? What is the target? Because we're not going to come down from 5 times more likely to die to 0 in 1 or 2 years. So at least if we have some interim milestones, then we know that we're working towards something. But right now, we're not really working towards anything. And I think that's where civil society and other activists in sexual and reproductive health, maternal health, can come in to hold the government to account, because we have the data, we know what's going on, and we've known what's been going on for years.
Yeah, even if UK has more data, indeed, there is no yet solution or anything, and many things to be done. I would like to ask also Estelle, maybe in her more academic perspective and more systematic, do you think there is any kind of ways to address these questions, civil society or government? And do you think that there is something that can be maybe similar to address it in France and Canada, since you work in both countries?
Well, I think that if I start with the case of France, starting from where from what I said earlier, I talked about the political emphasis about repression of immigration. I think this should be much less emphasized in the general discourse, in the general government discourse, because this definitely contributes to xenophobia. Xenophobia feeds racism, and therefore it contributes to the justification of discrimination and access to healthcare for foreigners. So I think just directly from what I said earlier, this will be definitely something to do. Now, there is something else that has been said by everybody. It's about the collection of ethnic and racial statistics. What I would like to say, comparing France and Canada, I think France is really a bad case. The government doesn't collect any of those statistics. And it's, in theory, it could be allowed, I think, to some singular researchers, but they actually don't do it because there's some kind of a taboo about this kind of statistics. The fear that it would formalize racial categories, make them look like if they were biological and so on. And so the result is that there's absolutely no data comparing the health of people according to the race categories they belong to. But not only that, it's also no data in the determinants of health, such as income, education, work, and so on. You can't see that. So I think I agree completely with Aimee. There's a lack too in Canada. But for me, being French and being at least in Quebec, at least there's a few. And more precisely, there's a few data for the COVID about the census. When people register for the census on the whole country, they say what race they think they belong to. And so for the COVID, if you take small neighborhoods, small parts of the territory, you can see what is the proportion of racial minorities, what is the proportion of people being infected, and you can compare that in between different pieces of the territory. And at least you have an indication. Like in Montreal a few months ago, you could see that in the pieces of neighborhoods, small pieces where there were the highest proportions of Blacks, the proportion of people being infected was 3 times higher. So at least that's some kind of indication. In France, you don't even have that. In France, you have to go through, where are you born? Are you an immigrant? These are proxies, but they are not precise, of course. So, well.
I fully agree with you, Estelle, and I feel like we have an understanding of the ethnopolitical situation in each of these places, and how also specifically how France influences the province of Quebec and how they address issues relating to race compared to other provinces in the country. And ultimately, the data related to race is almost an accidental finding because of how the census is made, relating to finding out about the racial or the immigration makeup of the country, and not specifically relating to health.
Thank you very much. It's really, really interesting. And indeed, there are many things to be done still. And we didn't find any perfect solution. Any country didn't find anything so far. So now it's almost 20:20. And I would like first to ask our speakers if they agree if we have 5 or 10 minutes delay to be able to ask the question from the audience. Is that okay for you? Thank you. Then I will let Yasmin start with the first questions.
Thank you, Sherian. We are going to share with you the question from the audience. There were many questions, so we won't have the time to answer to all the questions, but we choose some of them. And I would like to thank my colleague Hadil for the moderation of the chat box. The first question, you kind of answered to it already, but I'm going to turn it differently. The question was, what were the issues you faced as a researcher to collect racial data and information? And the question, the second question would be, how is there any other strategy to get the data when it is not available or when it's illegal to collect it? And I can let anybody answer, it's up to you. Estelle and Aimee, you talked about it a little. Rasha, do you want to talk about it, or Lazenya?
I can start. I think just to answer the first question, one of the challenges, I think, yeah, like as I said, the availability of data, especially statistic data, quant data on health disparities and the segregation according to different indicators. But also there's like in the region, there is so many other challenges that can, and different, and it depends on the context. So you have, first you have the, like security challenge, like actually travel there or like engage with especially non-public actor, non-official actors. So, and what we witness lately in the region is the shrinking of civil society space, and civil space where there's so like many organization, civil society organization have restriction in their to their work. So working with them can be difficult. Also access to official data, as I said, is not always facilitated. What else is like, these are like on top of my head, to be honest. Also like, creating trust and so on. And I guess like it really depends what I see, like from also like my work, because I did my research on the region also. We always tend to ended up doing qualitative methods or like trying to do mixed methods, so not dependent on quantitative, which is like very scarce, or trying what I can advise. There's so many organizations, so non-governmental organizations that actually generate data, so that can be used for your research if anyone interested. Yeah, thank you.
Thank you very much. Does anybody else want to answer? Okay, then Sherian, if you have another question to ask.
Yes. Now we have a question that is a little bit less about the data or solution, but rather more, I would say, yeah, really broad. And so the question from the audience was, what is the role of allyship in combating this problematic racist structure? What can we do as allies to raise awareness about this issue and use our social capital in powerful ways? And so I would also maybe expand this question, not only personally, but maybe in terms of institution or civil society. And I will first ask maybe Estelle to answer the question, and then Aimee as a healthcare professional, and see how also this question can be raised within healthcare professionals?
Well, it's a whole the question about systemic. When you say that racism is systemic, it means that it's really part of the whole society. So if it's only victims of racism who talk about racism, I think it's like ghettos the issue, and it makes you lose the perspective about the systemic dimension of this issue. So it's very important that it's from all the parts of the society that this issue is discussed. So for me, either you call it a lie or I don't know, it's just a part of being part of the society. You have the mandate, the duty to talk about it. Because whatever you do contribute to it by being part of the society. So yeah, that would be my answer.
Yeah, really, thank you. And do you think it's there is a challenge as a researcher to talk about these questions?
It can be very sensitive or sensible. I don't know. In French, sensible. Not sensitive. It's a very touchy issue. So it's you have to find the right words. You have to contextualize everything you say because it's very quick to misunderstand something. So yeah, you really have to be careful to not ignore or to not seem to ignore what you don't personally experience, but yeah, to être à l'écoute, to be aware. So that's it.
Yes, and listen to the experience of other.
Yeah.
Yes. And Aimee, what do you think, especially as a healthcare professional, it's even harder to respond to potential racist behavior of other healthcare professionals or something like this?
It's actually very easy, I have to say. In the last year, this has been, I think, a recurrent question I've been asked by both leaders in care, but also as trainees. So first of all, I have started to shy away from the word ally. And the reason behind that is I felt like I needed something that was a bit more powerful that explained what was required of people that we considered ally. And I use now the word co-conspirator instead. I need accomplices and co-conspirators. And the reason behind that is that you have to be willing to put yourself in trouble. If you are not willing, like, so basically in unequal systems, there's a couple of things that happen. Either you suffer from these inequalities, either you benefit from them. If you're not suffering from them, you are benefiting from them. By extension, you are also responsible, not necessarily because you designed these systems, but because you're accepting that you're benefiting from them and you're not being proactive to change them. And that's more than speaking on social media. That means that you have to be disruptive. And when systems are stagnant in that level, that the general population is accepting of them, the only way to yield significant change is by disruption. So if you are able to recognize as an ally, accomplice, or co-conspirator that you're benefiting and that we are not disrupting the status quo, the question next that you have to ask yourself is, what am I willing to sacrifice? That question is an individualized question that you have to ask yourself to see what is the level of dedication you have to actually yield equity in this world. When I'm seeing little different systems and different institutions writing about the support they have for indigenous communities or for minoritized societies, but it comes with no strategic planning in terms of how they're going to improve or change, this is simply performative. It is useless to us at this point. We are past the moments where we're still bringing awareness or trying to educate the population. The population has access to the same information that we do. The difference is that they may not have lived experience. So be willing to sacrifice money, power, status. And if you're willing to do all these three, you are on the right track. If you're not willing to do that, then you have to reflect on how committed you are.
Thank you. Really, really important. And I think we have a last question, and Yasmin will present it.
Yes, this one was for Lazenya, but I think most of you can answer the question. Do you think that being a woman of color impacts your understanding and analysis of systematic racism and its mechanism, and how? And yes, Lazenya, if you would like to start.
Thank you. I do think as a woman of color, as a Black and minority ethnic woman, it really shapes my understanding of racism because I have lived experience of it. You know, racism in the UK, it's very covert, it's insidious, it's not banging in your face, but you know that it's there. So I think having a lived experience as opposed to someone just speaking about racism, you know, it really shapes my understanding of what it is. And it's really the reason why I have started to be more vocal about it, because I am seeing, especially because of COVID, how it is impacting on the health of our population. I think pre-COVID, we knew it was there, but we couldn't really see the link as linear. But COVID has really shown, you know, the statistics in the UK as well. It's of the doctors and healthcare professionals who have died of COVID, it's mostly Black and minority ethnic doctors, you know, who are dying, who are having these more severe cases of COVID. So it really has, having that lived experience has shaped my understanding of racism, but also it's really given me the push to speak up a bit more about how it's negatively affecting our health.
Thank you very much. Rasha, would you like to go next?
I just want to add something like on Lazenya's response, because I'm also based in London. I think also the pandemic, but also the Black Lives Matters, this notion and awareness of racism gave I think was very useful in terms of giving us the language to talk about racism. And like, I think living or like experiencing something is something, one thing, and actually talking about it and having the language to talk about it is one thing. So I guess last year it was powerful for me to be actually like also like I'm working on in a human rights field, but it is different because I was able to actually express and talk about that, like have the right language to use it and understand it more, I think.
Thank you very much. Aimee, would you like to add something?
Yes, I know for sure. I think similarly to both Lazenya and Rasha, being a Black woman living in Canada, but also having grown up in Quebec specifically, where the culture is slightly different than the rest of English Canada. At this point, I've lived in four provinces in one territory in this country, and the flavors of racism or it might be the spices might be a little bit different. The main plate is still the same. In my personal background, I am married to an Indigenous man, so I do have 3 Afro-Indigenous children. Our experiences and the way it shapes our realities and our lived experiences in this country are quite unique and quite particular. So it makes sense to us when we say that we see and appreciate racism everywhere in every shape. Because of our lived experiences, and it really helps frame some of the needed changes that we see in different contexts, in different provinces or different territories, and what it looks like, and what power dynamics look like. So, of course, whether it's addressed to us or whether we're the victims of such racism, or witnesses of such racism, or participants of racism, because we often feel like because we are women of color or Indigenous or Black that we somehow are immune to actually contributing to white supremacy, but we can very much be actors of it. It really colors our lenses in a very different way.
Yes, that's true. Thank you very much. That will be it for the questions. Does any one of you would like to add something before we close the event? Okay. Great. This was a very insightful discussion. A huge thank you to you, our wonderful speakers, for sharing your knowledge and expertise with us today. And to you, the audience, for joining us and engaging in the conversation so greatly. We hope you enjoyed the discussion as much as we did. It was very, very interesting. Thank you very much again. And Sherian, would you like to add something?
Yeah, to finish, first of all, thank you a lot again for all the panelists and also our colleagues at the RAP initiative who help us with this event. And I would like to just remind you that you can still follow us WCAPS on social media, and also you can check out the RAP initiative webpage on WCAPS website, but also on social media. And if you are not a member for the moment, you can actually join us, and the membership is free. So you can just fill a form and you can select the Racial Upon initiative in the list of your interests. And I would like to again thank you for your patience, for your perspective, your analysis, and also for the time and concentration for the audience. And wish you all an excellent day or evening. And goodbye to everyone.